The Thalassaemia International Federation welcomes and endorses World Health Organization's efforts to alleviate the many health issues that migrants and refugees may have to face during the migration and resettlement period. Host countries have a humanitarian obligation to assist and support these population groups in receiving healthcare appropriate to their needs. TIF also endorses the framework of priorities and guiding principles to promote the health of refugees and migrants. TIF, moreover, is in full agreement with the progress report on implementation of the Strategy and Action Plan for Refugee and Migrant Health in the World Health Organization European region, reported by the Regional Committee for Europe in Rome in August of this year. In this report, however, it is stated that evidence of poor health among refugees and migrants is generally confined to certain infectious diseases and maternity and mental illness outcomes. Thalassaemia International Federation believes strongly that many chronic diseases may have been excluded from this statement, either because of inadequate diagnosis or inadequate reporting. Chronic disorders are often not visible unless special laboratory tests are performed. This is certainly the case for sickle cell disease and also even for a recently transfused thalassemia patient. Even though population movements have been a phenomenon known throughout history, the recent increase of population shifts from south to north and east to west have indeed brought with them an increase in chronic diseases which are above the general acute health issues that are expected. The recent migrations are from countries with a high prevalence of hereditary hemoglobin disorders to low prevalence areas of North and Western Europe. For example, of the 5.5 million global carriers of the sickle cell gene, about 80% are born in sub-Saharan Africa, from which most refugees entering Southern Europe, Italy and Spain mainly, originate. Thus, Italian thalassemia centers are now treating mostly sickle cell patients, where beta thalassemia was mostly endemic. Likewise, migrations from Iraq, Thailand, Syria, Afghanistan and Turkey entering Europe from the eastern borders of Greece and the Balkans are carriers of thalassemia patients and with hemoglobin disorders, while a good example is Sweden, which between 1998 and 2003 hosted 200 patients with hemoglobin disorders, while by 2015 these have been exceeded 3,000. Another example is that of Germany, where in 2014 only about 1,000 to 1,500 sickle cell patients were recorded, while in 2016 a neonatal screening study revealed a frequency of sickle cell disease in 2,385 newborns, probably of sub-Saharan ancestry. Even more worrying is the flow of refugees from war zones to neighboring countries, which have also a high burden of these disorders. These protracted emergencies have created a great humanitarian crisis, which has affected Europe to a great extent. Many have gone to Lebanon, which hosts around 1.5 million Syrian refugees, while Jordan has received around 700,000 and Egypt over 100,000. These are countries which have an indigenous hemoglobinopathy problem, a burden with which they are hardly coping for their own population, yet no knowledge exists about the fate of the refugee patients in these countries. Who is responsible for their care is not really known. In a TIF study, which is still unpublished, of 2015, there were over 200,000 Syrian refugees in Europe, of which 1,000 to 10,500 are likely to be carriers of beta thalassemia. From Afghanistan, also from the same study, another 311,000 were residing in European countries and around 10,000 are likely to be carriers. This is evidence that it is not only affected patients are increasing, but also healthy carriers who may affect the future birth incidence of these conditions in Europe. This calls for long-term policy considerations. According to the WHO 2016 framework document, it is recommended that through information systems there should be analysis and assessment of refugee and migrant health. There should be emphasis on disease prevention and quality of care, in particular for patients with disabilities. It is of concern of the Thalassaemia International Federation that no action is being taken for the survival and welfare of patients with chronic disorders, and especially those with hereditary anemias, who require lifelong and complex treatment, which includes blood transfusions and the need for essential drugs to chelate excess iron. These patients survive best when managed by experienced practitioners. In some developed countries, such services are being offered, although experience may have not yet developed. Through this statement, Thalassaemia International Federation wishes to bring the issue of chronic and hereditary disease to the attention of all host countries in Europe, urging them to identify patients and plan for their treatment in the best possible way, adopting policies for both prevention and optimal care. These are policies which ensure survival in these diseases, which could lead to early death if not well cared for. In contrast, a good quality and productive life may be expected if given optimal care. Finally, we would like to express a sincere appreciation for the humanitarian efforts of the World Health Organization concerning the health of refugees and migrants. On the basis of TIF's long collaboration with World Health Organization, we confirm a desire to collaborate in as many ways as possible with World Health Organization for the promotion of the issues raised in a practical and effective way.